Hello and welcome everyone. Come on into our session today. Thank you for joining us live. We're really glad that you are here with us today. We will start officially in about 5 minutes. So get settled in, make sure you have in front of you what you need to stay comfortable for the next hour. We're really excited to be here. Welcome, welcome everyone. And as you're settling into the session, feel free to say hello in the chat. We love to see your messages. Feel free to say hi. Let us know where you're zooming in from. Kind of grey here in Melbourne where I am at, but it might be sunnier in your part of the world. I don't know. Welcome to everyone who's joined us live. Settle into this session. We'll be starting officially in a few minutes. As you can see, the whole team is here today. We're really excited to spend some time with you in this bonus follow-up session. Take your time to settle in, make sure you're comfortable. We're looking forward to sharing some Q&A time with you. Welcome. Nice to see some chat coming through. Welcome, everyone. Thanks for joining us live. We'll be starting very shortly, just in the next couple of minutes. And you can see the whole team is with us today. We're all together today. We're really excited to share some content with you today, to answer some of your pressing questions. This is an important bonus session for this conference. Great. Great to see that we've got some people live with us this morning. Thank you for taking the time. It's great to be here. Thank you for sharing and coming on board live with us. We're really looking forward to spending some time with you this morning, our bonus 1 hour session today with some Q&A. You can see the whole team's here. Welcome, everyone. We'll get started officially very shortly. Be sure you've got what you need in front of you. Please do stretch and breathe and fidget and have your camera on or your camera off, whatever floats your boat. Make sure you're as regulated as you can be in this time. All right, and as we are clicking onto the hour, I'm going to make an official start. Hello, everyone. It is my pleasure to welcome you back to our online conference supporting autistic and ADHD folk in the perinatal period. I'm Bronwyn. I'm your host and your conference curator, and I'm also the director of the Perinatal Training Centre. Thank you for joining us here in this space. 5 weeks ago, we had the main portion of the conference, and our 6 dedicated speakers provided 8 presentations across 3 days. We know them from your feedback that you really enjoyed and valued both the content and the ways in which each presenter delivered their messages. Thank you for letting us know what you enjoyed. This is our final session to wrap up our conference, and today we have a dedicated hour to answer some of your most pressing questions. You will remember our 6 speakers who are leading the way in neuroaffirming perinatal and infant mental health care. You can see we've got the whole team here today. I know you remember them, but please say hello again to Jata Elliott, to Sarah Harrower, to Amy Pember, to Jilly Ryan, to Sarah Edwards, and to Ali Taylor. We've received quite a lot of questions. Thank you for taking the time to submit them. Not all of the questions that you submitted will be answered today, but we do have a range of questions to address, and you will hear from all of our speakers. They have received the questions ahead of time and will provide a pre-prepared answer. The rest of the panel might also chime in, but we'd like to let you know that some of the questions, well, probably all of the questions actually, are quite complex. And due to time constraints, of course, the answers will not be complete, just so you know. Our intention is to open up discussion and open up explorations of concepts, and not to provide answers that are going to be finished with full stops, but rather with question marks and more space for us to continue to explore and get to know over time. And because this is an emerging space as well, naturally we are working in a space where we are providing answers to questions as best as we know at this time. Let's get to our first questions then, and we're starting with the space of pregnancy, labour and birth. So the very first question is directed for you, Jata. And the person who has popped in this question to our survey has said, thinking about labour and delivery and ways that we would like to see patients advocating for themselves by asking for clear explanations of procedures, including pros and cons. And we would encourage, of course, the need for them to speak up if they need more time to regulate themselves before an intervention is administered. So thinking about that context and how you beautifully in your presentation encouraged us to work with people to advocate for their needs. The question then is, how can we support patients to continue to advocate for their needs to be met in the birth room when their reasonable requests are met with resistance or refusal by medical or hospital staff?
Yeah, thank you. There's a few layers to that question, hey. A lot of it, well, having more visibility. So I don't know if any of us mentioned about the sunflower lanyards. A few of the hospitals now are on board with that. So that kind of sends a message to staff that you have a hidden disability. Yeah, I know where I work at Fiona Stanley, their using that, so that's really good. But that's like one clear way as well of like communicating to staff that you might have different communication needs. It's one of those things as well where like ideally before birth you can practice some like role plays of meeting resistance when you're in labor and birth, but also for the support person to be prepared to be the advocate too. So even if they're prepared with some scripts and when to step in and yeah, so support people if it's a doula, if it's a partner, but if they can have some prep as well on what your needs are, having it clearly in a birth plan, and that including communication preferences as well, and having those sensory needs met as well, so that you're in a regulated place to be able to advocate. It's much harder when you're dysregulated to advocate for your needs. Practical scripts. So I've seen people have these like laminated versions as well. So you've got the brain tool, but some similar kind of like scripts as well for when you need to ask for more time. Assertive phrases like just, can you speak slowly? I need to pause. Can I speak to another member of staff? Just anything that can kind of like buy you more time as well to like regulate and find your voice to speak up. I think it helps as well, like a lot of it is antenatal preparation, but if you can just have that awareness of like how the system is in terms of like systemic pressures and hierarchies, and just so that you're aware that like it's not personal. Like often it's like staff who are like under the thumb day in, day out. So yeah, that you're advocating, but you're also not taking it personally, that you have those boundaries that are up as well, that it's not perceived as like rejection, because that can really put you in a place of like feeling unsafe. Yeah, I think like that like briefly covers it. Yeah, and you can always ask for another member of staff as well. I think that's important to know, that if you're receiving a lot of pushback from a certain member of staff, maybe it's time to ask for somebody new to be your care provider as well, and that's also an option. A lot of hospitals have like an escalation policy as well. So you can ask for like a more senior member of staff, and just advocate for maybe like new people in the room as well.
Some really practical and helpful points there. Thank you, Jada. I love that. What I'd like to do is stick with this topic, but Sarah Harawa, I wonder if you could briefly add to this question too. Jada mentioned antenatal preparation and you spoke with us about pregnancy. Sarah, what are your thoughts on how clinicians could help support pregnant people to think ahead when planning their labour and birth experiences, in case they do encounter medical staff who, for whatever reasons, are unable or unwilling to support accommodations requested by the patient?
It's such a good question, and Jada gave such a wonderful answer there. And I will be sort of repeating some of the points that they made. And I think it's important we hold in mind the duality of this, in that, yes, the people who are working under a lot of strain within the medical system are struggling, but at the same time, we need to protect our own experience as, entering into the portal of parenthood, really. So I was thinking from the psychological perspective, particularly with like ADHD, it's really important to recognize that self-advocacy often breaks down not because we're not prepared or not capable, but because under stress, nervous systems default to survival responses. And truly, we could say this is the same for all birthing people. So for many people, also navigating relational trauma, sensory overwhelm, demand avoidance, or even executive functioning differences. This could look like shutdown, freeze, or people pleasing, which is why, Jada was saying that planning for advocacy really needs to start before we're in the birth room, because we want to reduce as much cognitive and emotional load in the moment at the time. So Jada mentioned birth planning, and one tool that I really like, I think I shared it in the earlier sessions, was the Birth Map by Catherine Bell, or I mentioned it in Jada's. So it moves beyond sort of that fixed birth plan, and it helps people to see different pathways and possibilities and like decision points ahead of time. So it's kind of like this almost never-ending flow chart. It's accessible in book form. There's a game that comes with it, and Catherine runs monthly Zoom sessions, I believe. I was just looking at her website recently. Another tool that can be really helpful is the SARC Sensitive Practice Request Form, which is from King Eddie's Hospital in WA. So the acronym SARC is SARC, which is, there are 3 different versions. There's like an easy read version, more of a visual prompt version, and then a regular version. It's for any sort of health appointments, but it can be adapted to use in labour and birth, or even during any antenatal appointments. So it really helps to communicate like sensory, trauma, or any other adjustment needs. Jada did mention also involving support people. So I think it's important to note that that could be a wide variety of people. So it could be your partner, a friend, a doula. Hopefully you do have a midwife with you who's birthing person centered. Another option is a student midwife. So student midwives are free and are often really, really valuable. And the wonderful thing about student midwives is they're not so caught up in having to do all of the paperwork. They're very person centered, which is wonderful. And I think including those support people in your planning sessions, like if you're a psychologist or a mental health worker or a midwife, and you're working with this pregnant person, inviting the support people in so that they're a part of the planning process as well is really important. I wanted to mention the BRAIN framework, which I know that Jada mentioned as well. And again, it's a protective factor the more that these are explored in pregnancy. I think it's really important to note that support people can also have some scripts to use. So I was thinking something like, we've discussed these in advance. Can you please refer to the birth plan? Like all you have to do is redirect as the support person to that plan. And for the birthing person, they could just say, I need time to process this before I decide. Because ideally, you don't really want to be talking in birth anyway. I think it's also important during pregnancy to remind those people that they have the right to decline care as well. That's part of informed choice, requesting a different staff member or even exploring different models of care. So if you as a birthing person are starting to feel unsafe during your antenatal appointments, or you're met with some resistance, I think that's an opportune time to change. Like you don't actually have to stay with the one decision that you made earlier in your pregnancy. You are allowed to change. And you can do that at any point. You could do that the day before you go into labour. You could do that in the middle of labour. There's no rules around that.
That permission giving is very
yeah,
helpful. Thank you, Sarah, for raising
it
that.
is, isn't it?
I don't want to interrupt your flow. Keep going.
That's okay. I'm at the very end now. I was thinking what we want to do is protect the autonomy of the client. And my final note is that advocacy isn't an individual task of the birthing person. It's really a collective task because it's relational. We're planning for it together. And when we do it that way, we can kind of stand up against those systems that resist. Yeah.
Beautifully said, Sarah. Thank you so much for that addition. Ellie, can I invite you to make an additional comment to this question?
Yeah, really beautifully said. And I'm so glad to, that we're talking about partners and support people too in such an intense, tender space, because I've worked with quite a few parents and couples where they went in as a partnership to the birth experience, and maybe the partner caved, if you like, and sort of sided with an obstetrician maybe. And then the woman felt like she was completely abandoned in that process. And then that causes relational trauma. And so couples are going home not with just a new baby, but also with a new rift in their relationship and this relational trauma. So I think it's really, really crucial to have where it's a couple or where it's partners, that they are on the same page and a team going into this. And just keeping in mind too that it might be the partner that's the neurodivergent one, and so they might actually need more support and preparation than the birthing individual. So really grateful that you've thought of that. Yeah, thank you.
Good points, Ellie, and we hear that a lot in our therapeutic practice, that's for sure, when that happens and there's the rift between the couple. Thank you. I'm going to move us along now to a question related to feeding. So this is a question for you, Jilly. And this is actually, it's a little cluster of questions that has come through related to DMER, that's dysphoric milk ejection reflex. So Gillian, can you say more about dysphoric milk ejection reflex and how we can support parents who may be experiencing it? Can you talk to the identifying features, why it's more common in ADHDers, what it might feel like for the person experiencing it, how we might assess for whether or not someone might be experiencing DMER, and what other ways then we can provide support?
Yes, thank you for the question. Thanks, Bron. DMER or dysphoric milk ejection reflex, it's a physiological condition that causes significant distress during lactation, breastfeeding and chest feeding. But yeah, it is under-recognised so far in clinical practice. So there's not a lot of research out there yet, but studies show anywhere from sort of 5 to 14% of breastfeeding or lactating mothers and parents can experience this phenomenon. But of course, with limited research, that's likely to be a much higher number. So DMER is characterised by a sudden and brief onset of unpleasant or really distressing emotions immediately before or during the milk letdown reflex. So this can happen when a parent is breastfeeding or chest feeding or pumping, and with spontaneous letdowns as well. So especially in those early days when parents are having lots and lots of those spontaneous letdowns, they might experience it then as well. And DMER tends to improve or resolve over the course of the first year, but not always. So the underlying cause of DMER is not yet fully understood, but current research points to 2 possible explanations, and both of those involve oxytocin. So the most common theory out there links DMER to the temporary drop in dopamine that coincides alongside the oxytocin surge that's responsible for triggering the milk letdown reflex. So while most people don't consciously feel this drop in dopamine, people whose nervous systems might be more sensitive to hormonal shifts, and that includes our autistic and ADHD parents, can experience this dopamine drop more intensely. And that's what triggers the emotional distress. And then another theory suggests that oxytocin itself, while it's essential for bonding, it also primes parents to protect their infants. And so in some, this protective response might be hypersensitive, with the oxytocin surge inadvertently triggering a brief state of fight or flight, and then the associated negative emotions. So we definitely need more research to try and figure out exactly what's going on. So lived experience reports, so what it can feel like. Descriptions vary, but common themes include a wave of dread, emptiness, or homesickness, sudden and extreme anxiety or irritability, and feelings of despair, self-loathing, and loneliness. So it's really awful for the parents experiencing this condition. So as far as assessment and differential diagnosis goes, accurately identifying DMER obviously requires informed questioning and assessment, and it's distinct from breastfeeding aversion, which involves persistent, unpleasant, more physical sensation throughout the whole feed. And we often see breastfeeding aversion develop later in the feeding journey, often when parents might be pregnant for the second time and continuing to breastfeed or chest feed. And it's also distinct from postnatal depression and anxiety and postpartum psychosis. But that's not to say that those conditions can't also occur alongside DMER. So of course it's important to screen for all of those conditions, but DMER shouldn't be dismissed like only through a process of elimination. We really need to be checking for that as well, and just remembering that it's a recognised physiological phenomenon. So we can sort of try to untangle and figure it out by asking parents whether they experience a sudden short-lived emotional shift at the start of a feed. So not all parents are aware of the letdown sensation when they're breastfeeding or chest feeding. So they might not link those emotional sense or experiences with the letdown. So we really need to try and unpick that for them or with them. Support strategies. So currently, there's not a lot out there, but education and validation are really central and often enough to support a parent through the experience. One mum said, just knowing that it was a real physiological condition gave me so much relief. Second time around, I felt fully prepared for the feelings of dread and anxiety that I experienced with each letdown and felt much more able to manage them. And then some practical strategies include supporting nervous system regulation through neuroaffirming care activities and environments. There's some emerging research that has come from elite sport research, and it's tied to dopamine, that drinking iced water immediately before and during a feed can help a little bit because it can give that dopamine boost. Stimming fidget toys and reading or listening or watching something enjoyable during letdown as a distraction. And then pointing parents to the website d-ner.org. That's a website that's been developed by an IBCLC, so a lactation consultant who experienced DMER herself, and it's an absolute wealth of knowledge there. There's links to all the current literature, lived experience, so there's really great info there. And then just your national breastfeeding organisations as well, such as ABA here in Australia or La Leche League internationally. So yeah, really with education and sort of tailoring strategies, we can sort of support to reduce the distress, promote lactation success, and ensure that parents, and particularly our neurodivergent parents, feel seen and supported.
Beautiful, wonderful. Thanks, Gillian. Really enjoyed listening to that. And it's easily missed, I think, DMER. It can be misidentified as depression or a mother who's not coping or something like that. So yeah, just awareness around that is really helpful. Moving us along to thinking about the neurodivergent couple. So that's you, Ellie. And so we had a couple of questions, but I guess just to set the scene by way of reminder, Ellie, you explained how complicated relationships are generally. And then when we add relationships at the perinatal stage, it's even more complicated. And then let's add more complication when one or both of the couple are neurodivergent. So that's even more complicated. So one question we have is, well, what do we do with that? What if in the course of my work with a parent, it turns out they are neurodivergent? How can I help support both partners with this new information?
Yeah, welcome to my world. And also too, speaking to this from a lived experience perspective, because, you know, that was me and my husband too, you know, perinatal, oh, all of a sudden neurodivergent couple. Yeah, so Yes, so it was a challenge to do it in an hour. I'm going to try and attempt to do that in 5 minutes. I think the first step is to normalize that, especially these days post-COVID, it's actually really common for adults to be diagnosed with this. So that's kind of done us all a favor, I suppose, that we're now like, okay, well, we probably know people that have been diagnosed recently as adults, certainly more than 20 or 30 years ago. So that's a good thing to do. And we know that it's more likely to become apparent during times of stress and times of transition as the parent transitions into parenthood is. And so awareness is so helpful, So some couples, I guess, be prepared for a range of emotions. Some couples will be really relieved that this finally makes sense of the struggles that they've had. I know that that was the case for me and for us. We were really happy. Well, actually, no, that's not true. I was happy and relieved, and my husband was resistant at first. So be prepared for a range of emotions with both the individuals and between the couple. But I think just, psychoeducation, awareness raising, validation, normalizing all the go-to tools that we're all using anyway with everything else really do apply here. Diagnosis can be a long road, although it's speeding up now with GPs able to diagnose. That's new. So, if we think of it as a journey, even just, providing a warm referral at the very beginning, or even just being, like a understanding, supportive, validating professional can help parents and couples feel like it's a good thing to do to access help. I think I spoke in my thing about, we had a negative experience at the beginning, and that really delayed my husband's help seeking for a couple of years. So I think even just being warm and supportive is a great start. I think, parenthood generally is so much about parenthood changes absolutely everything. And it's really about knowing how to work with the changes rather than against the changes. And I think that applies particularly to neurodiversity within a couple, or neurodivergence with one partner. And just really helping them to understand how this impacts them, not just as individuals, but the dynamics between the couple. And bringing them in to manage it as a team. And, parenthood obviously is the perfect time for them to start working as a team. We want that for all couples, regardless of their neurotype. So using it, I guess, as recognizing both the challenges for parents and couples, but also recognizing this as an opportunity, because parenthood changes relationships anyway. Parenthood activates attachment anyway. So they're already, having to maybe learn some new skills or have some raised awareness about what those two impacts alone can have on their partnership going forward. And then extending that to to tailor to each partner depending on their neurotype. It's kind of in some ways a good opportunity, like it's actually in some ways a really good opportunity for something like that to happen at this point in their relationship, because I've often seen more often where it's gone undiagnosed for really long periods of time, and that's often ended the relationship. It's often lent to the end of the relationship. So actually it's a great thing if it can be picked up now. It's actually, it's prevention at this point.
And sending that message would be helpful, right?
Yeah.
Especially if when the couple is in distress, to be able to say, let's look at this as a prevention for, and so we can safeguard your relationship for future and whatever. Yeah.
Absolutely, absolutely. And at a personal level, for us, it was really me kind of getting used to the idea of falling out of love with the person I thought I was with, and making space to fall in love with the person that he actually is. And
Aw.
yeah, I know. It's actually, like it was a really good thing for us. And, so I say, I say to couples that regardless of the neurotype, that, you know, becoming a parent takes your relationship to a whole new level. And it's a little bit like falling out of love with the relationship that you had, but it's not the end of the relationships, it's the start of a new one. So, you know, the neurodiversity comes into this. It's part of an umbrella, I suppose, of a way of working with couples.
And that is the becoming, isn't it, Ellie?
That's the becoming.
Like that's the becoming, that we're all in that space. Yeah.
Becoming, and it's just the start, particularly at this point in a couple's relationship. It really is the start of a new relationship, and that can be a really great thing.
All right, thank you for those insights and comments. Appreciate that. Thanks, Ellie. Moving along then, away from thinking about the couple relationship, we have a number of questions now on the early postpartum, parenting and infant experiences. I'm directing the first question in this set to you, Amy, and it's a big one, right? Because someone is pulling at the thread of the attachment space. And so it's a big question. Take your time to answer, and allow me to, there's a little bit of preamble to this question, so allow me to read what this person has said. In the field of infant mental health, much import is placed on relational experiences defining attachment and attachment classifications, with those associated behaviours that come with each of those attachment patterns. As autism has a strong relational context, can you point me to research that has looked at attachment classification of autistic infants or children? And is there an identifiable trend?
I have prepared something I'm going to read, but
Yes.
yeah, I'm going to go with that, and I might just add something if we have time. But so in infant mental health, attachment classifications, so secure, avoidant, ambivalent, disorganized, are seen as pivotal in understanding the child and the caregiver relationship. However, when they're applied to neurodivergent people, and particularly to autistic dyads, these frameworks may actually obscure rather than illuminate the nature of the relationship unless we adapt our interpretive lens. So research indicates that autistic children are capable of forming secure attachments. Teague et al. 2017 conducted a systematic review of 40 studies and found that approximately 47% of autistic children were classified as securely attached using the strange situation procedure. The strange situation procedure, in case people are not fully aware, it observes how infants respond to brief separations and reunions with their caregivers, focusing on behaviours like exploration, distress, and proximity seeking. However, it was developed using believed to be neurotypical infants as the standard. So autistic infants may regulate differently, and they may show differences in eye contact or in affect, which can be misinterpreted as disorganized attachment, when in fact it's actually sensory or social communication differences. And this is what underscores the need for neurodiversity affirming adaptations in assessment. And so with regards to the question about the identifiable trend, higher rates of insecure or disorganized attachments are reported, but I argue that it's due to misinterpretations of neurodivergent behaviors. So, and I'm actually going to make direct reference, this is my ad lib bit, to Andrew Whitehouse's work. And I know that this will be controversial, and I know that there'll be many people that might watch this and think that Andrew's work is amazing. However, what his interventions are doing is teaching children to math.
Mhm.
Because if we are using eye contact as a way to determine if a child can communicate, and we are expecting them to become, you know, able to maintain eye contact, whatever, that is not a child that is actually doing what feels comfortable for them. That is a child doing what is expected of them.
Mhm.
And I know that people can argue that an infant cannot communicate that, but we autistic adults can, and there are many autistic adults that have gone through those kinds of interventions. So a more recent analysis, meta-analysis by, and I can't say this name, but Pizzetti Kotz et al. 2022 found a moderate to strong association between maternal sensitivity and attachment security in autistic children. So a stronger link than is typically seen in neurotypical populations. This reinforces the view that it's caregiver attunement, not the child's neurotype, that's the key predictor of secure attachment. Building on this, Lee et al. 2024 found that parental insightfulness, or the ability to interpret and respond to a child's internal states, was strongly linked to parental sensitivity and secure attachment outcomes in autistic children. Similarly, another name that I can't say, it's like Van Ijendoorn et al.
Mhm.
2023 showed that video feedback interventions designed to increase caregiver responsiveness significantly improved attachment security across both neurotypical and neurodivergent samples. So I'm just going to. These findings underscore a crucial point that when parents are supported to attune to their child's unique communication style, secure attachment is not only possible, it's probable. So if you're aware, Milton 2012 introduced the double empathy problem, which highlights that communication breakdowns between autistic and non-autistic individuals are mutual. So rather than viewing autistic individuals as lacking empathy, this theory emphasizes that reciprocal misunderstandings arise from different neurotypes. This perspective suggests that autistic children's attachment behaviors may be misread by neurotypical observers, not due to deficits, but due to differences in communication styles. And building on Milton's work, Shaw et al. 2023 proposed the triple empathy problem, which adds a third dimension: the clinician's role in interpreting interactions between autistic individuals and their caregivers. I'm going to make direct reference again to Andrew Whitehouse here. This model posits that clinicians, influenced by their professional training and their cultural norms, may misinterpret neurodivergent relational behaviours, leading to potential misclassifications in attachment assessments. Now, I have had much delight in recent years of getting to work with a dyad by telehealth, where the infant was blind. And my experience of that was helping that particular parent to trust her actual lived experience of her baby's bond with her. So, recent research on infants born blind offers a compelling comparison. A 2023 study by another name I can't say, it's GUI et al., found that despite elevated parental stress, blind infants showed comparable joint engagement with their caregivers when those caregivers were attuned to non-visual cues like touch, vocal tone, and proximity. Earlier studies, so Freiberg et al. 1975, Bigelow 1990, similarly emphasized that secure attachment depends not on visual cues, but on caregiver sensitivity and interpretive flexibility. And I think we can draw some, you know, what's the word? Associations. When we think about, again, direct mention to Whitehouse's use of eye contact as a intervention, it's crap, okay? That's my blunt autistic response. So traditional assessment tools, such as the strange situation procedure, may not adequately capture the nuances of autistic attachment behaviours. Disorganised attachment is often over-attributed in autistic children due to unfamiliar affective signalling, unfamiliar to the clinician, okay? Sensory-based regulatory behaviours such as rocking or avoiding gaze. I don't know if any of you are watching, but I'm seeing many of us as panelists rocking at different times. I don't think that that indicates that we are not secure in our attachment. And clinical misinterpretation through a neuronormative lens, direct mention of Andrew Whitehouse again. So, just as tools have been adapted for blind infants, we must adapt our frameworks for neurodivergent dyads to ensure difference is not mistaken for dysfunction. Clinicians must reflect on their biases and apply neurodiversity affirming approaches that validate varied expressions of attachment. Autistic children, like blind infants, are capable of forming secure attachment, but only if their behaviours are interpreted in context. The double and triple empathy problems remind us that attachment is not just what the infant does, it's what we see and how we understand it. If clinicians remained anchored in neuronormative standards, we risk pathologizing meaningful attuned relationships. So just as blind infants taught us to listen beyond the eyes, autistic infants invite us to attune to their sensory, emotional, and relational languages with respect, flexibility, and care. And just a final note, there's been a lot of discussion in different places online about where well-meaning people are saying, oh, but when I'm watching attachment, I'm not just looking at particular behaviours. And I'm going to argue that we all have implicit bias, and I do use observable behaviour to make inferences about what I think is happening. And that is me knowing that observable behaviour is not necessarily a good indicator of internal experience. And so if you're listening to this and thinking, oh, I don't do that, I invite you to go away and just consider, what if I do? How is that impacting on what I see in a dyad? And how does it limit the way that I support the dyad to bond as they need to? Thank you.
Thanks, Amy. Well said. Lots of nodding heads here with the panelists. And I guess, anyway, I won't add anything too much. There are always things to add, but I guess just to say it's so important to identify neurodivergence in the parents, because if you've got a neurodivergent parent, likely you've got a neurodivergent baby. And so it really helps to have that understanding. And also, as you're talking about behaviour, it's so important to look at and get to know a dyad and a little family around the function of the behaviour. What is the function of this behaviour? Not this is the behaviour and making an interpretation based only on that. We are considering for this little dyad, what is the function of this behaviour, of this communication? That's vital to consider. All right, Rest, Amy. We'll come back to you with another big question soon. I'm going to pull in now Sarah Edwards. I'm holding in mind, Sarah, that you presented on dads and encouraged us to think about dads. But this question could be for mums or dads. And the question is, what are some ports of entry when a perinatal client presents as autistic and or ADHD, but does not appear aware of their neurodivergence? It hasn't landed on them yet, or they might have been told, but they're dismissive of that idea. What are some ways that we can navigate these early conversations about neurodivergence with our clients?
Thank you, and thanks, Bron. It's a really important question. And I was sort of reflecting on my own experiences of introducing neurodivergence with my clients. And I was thinking there's probably one client I met for the first time and introduced it within half an hour. And there's one client that it's taken years of unmasking to really actually see that neurodivergence lies underneath. So I think really it's such a nuanced conversation, and the timing of when you deliver the possible, like, this is an intervention in itself, I think really has to be considered. And I think also given, the pressure around, the perinatal period, again, probably suggesting, a different neurotype at, the week before they're about to go into birth may not be appropriate, perhaps sort of doing some of the sensory interventions, which may be helpful. So I think really it's, firstly, I think it will say rooted in probably experience or some understanding of, the things that you're listening out for. So I think when we take a really good thorough history, really good developmental history, it's having ideas in mind of things that might turn up in the conversations that we are having. I think it's being able to sort of attune to where our patients are, whether, they are in significant distress, and whether it might be that neurotype and getting sort of medical support or medical intervention might be a way forward. Or, I think particularly for the most part, I mean, it probably helps that I work in this space now, so most people have had some exploration of their neurotype before they see me. But I think clinicians that are newer to this space, I think, I think sometimes, I think I've been struck often that when I have raised it, it is not brand new. They've either done some reading about it, or they've discovered something online, or someone has sort of suggested that they might have traits. So sometimes there's almost a relief that someone who is professional sees it. And sometimes that ends up being a bit of a port of entry for sort of exploration. So sometimes the conversation will go, I will introduce the idea of neurodivergence, and I will be specific around what I'm considering. And I'll probably sort of list some of the things that have come up in conversation or the developmental history. So those will be things that I'll sort of talk about. And then I'll encourage them to go away and have, sort of do some research or do some reading, really engage in social media, or make watch TikTok and make a list of all of the things that they relate to. And, I think I've probably had, 2,000 words come back to me before via email of things that have been found. And sometimes that's almost diagnostic in itself, right? Like a hyper focus. So, I think sometimes even just the way of suggesting this and using it as a port of entry of exploration, I think sometimes, helps, things sort of come to the table. I think for the folks that are more resistant, I will say that probably I've had more resistance to autism than ADHD clinically, because of,
Yeah.
the standards that exist in our understandings of autism. So, I think often that takes longer to land, but, we
Yes.
take the time that it takes, right? And I think probably sometimes as you move through understanding and working with and treating ADHD, sometimes autism pops more and that sort of becomes more on the table. But I think, like any of the psychological stuff or any of I'm coming at this as a psychologist, anything that we come at as a psychologist, we're sort of doing a lot of work in the background. We do have some information about the clients. We don't need to show our cards all the time. So, I think even just knowing that, we can still support our clients in really neuroaffirming ways without them having a diagnosis at all. Because I think I saw this beautiful quote somewhere, and it was probably something, all of these, it might have been yellow ladybugs, it might have been these interventions help everybody and hurt nobody. I think maybe I've got that wrong, but I just think, teaching women or birthing partners and, in the context to advocate for themselves and have really good care and, setting up really good support networks. I think really, all of our patients can benefit from this. It's not just our neurodivergent folks. So I think sometimes, and I think probably the other part as well is I also have to humble myself that I might be wrong as well. So I think sometimes I might, there might be some resistance because I might be completely off track as well. So I think it's also reflecting on my own desire or my own ability to kind of look at the patients in front of me. And sort of being able to go, it might not be landing for you, but I need to kind of check myself and check my agenda in terms of what it means for you to kind of understand this about yourself. So I think we can do lots of lovely work, but I think it's really about, it's no surprises to anyone. It's attuning to your clients and figuring out, is this the right time? Is this
Yes.
helpful?
Thank you for raising that at the very beginning too, and giving your example of I've raised this half an hour into our first session versus, some years into a therapeutic process. So there's no one right time. There's no one right way to do this work, like pretty much all of the work in perinatal and infant mental health. And so an attuned clinician, an attuned therapist is going to, we'll give our best go at finding the right time to raise something, wonder about something, or listen out for it in the language, and it's going to vary. I guess the other bit about that too, Sarah, is that for someone who is just circling right back to the question for that person that, what do you do if they don't see it or they don't want to see it? Well, we can't make anyone see anything if they don't want to see it, right? And if they don't want to see it, that's cool. Like, we don't have to label it. They don't have to wear the label or whatever, but we can still work with them in a way that is neuroaffirming, that can meet their accommodations, whatever, and we don't have to name it. And sometimes that can be the most protective way forward for that individual. Yeah.
And I forgot
Thank
to
you.
sort of touch up watching the time, but I sort of forgot to
Yeah.
touch dads as well. But I think probably when my neurodivergent folks recognise that they are neurodivergent, they sort of say, well, all of my friends and all of my family are also neurodivergent. And so often the port of entry into discussing the partner's neurodivergence is that when they come into the room, sometimes this is already in their mind. And so then I can sort of wonder gently with the partner, have you noticed some traits about yourself? And that's sort of how it comes about, because everyone sort of has this experience of going like, I'm kind of surrounded, right? And so
Which is normalizing.
it's so normalizing. So that's probably generally how I get at that too, right? Is that, you noticed, that your partner is, and, in my practice, it's very common. So I think that's how I come at it with dads too.
Thanks, Sarah. Ellie, did you want to say something?
I was
Briefly?
just going to say that, involving partners as well can also be
Yeah.
really helpful, because it can soften everything if partners are involved, and then they're going to take those conversations home and continue those conversations. So I think setting the partner up to be a support as soon as possible can also really facilitate this whole process. Yeah, beautiful. Lovely, Sarah. Thank you.
Before I move to our next question, there's some things coming through in our chat about a request for resources and for the things that are being mentioned, and the links to research articles and so on. We will endeavour to collate something together after our time together today and send it out to everyone. So thank you for those questions. We're on it. Our next question, I'm directing this to Sarah Harrower. And this question, Sarah, is: an autistic client is upset and annoyed by family members holding her baby, including grandparents, aunties, this kind of thing. What's going on? Can you speak to this experience and what might be going on for this client?
I can do my best, and I'm going to shorten my answer a little bit. But I really want to say that this is a really common, valid experience. And when an autistic parent feels upset or irritated or distressed by people holding their baby, it's rarely just about that small moment in time. There's often a lot happening beneath the surface. And for us as clinicians, it's really important that we help to unpack that with a lot of care and without judgment. It's really important that we're mindful of where we as clinicians might unintentionally invalidate or overlook what's happening. So sometimes, even with the best intentions, we might actually encourage holistic social norms, so non-autistic social norms, such as, it's good for the baby to be passed around, or assume that family involvement is always supportive. But for many autistic parents, the expectation feels overwhelming. It can feel unsafe or even triggering. We also need to watch for framing the parent as overprotective or socially avoidant, when in reality, those parents might be navigating their own sensory needs as well as nervous system regulation. So holding space for those needs and not pathologizing them is really central to trauma-informed neuroaffirming care. I wanted to note that autistic people do navigate the world with unique social patterns. And as Amy has said, there's really limited positive information about what bonding looks like for autistic dyads. So when a particular parent's connection might feel like it might be protective or intense or structured differently to what family members expect, then that can be misread. And that can also come down to the double empathy problem, where another family member might misinterpret what's going on. I also wanted to highlight that it could be some executive functioning differences as well. So for that autistic parent sitting in that moment, emotional regulation, planning, navigating those really complex family dynamics takes a lot of mental effort. And especially postpartum. So if you add in demand avoidance and someone says like, pass the baby here, that can feel really impossible to respond to. So I think as a clinician, a goal that we might work on with a parent is preparing those boundaries in advance, like coming up with some scripts, or even just helping them to understand what are my boundaries, or what could they be. Another point that I wanted to make is that for many autistic parents, the baby becomes part of the sensory regulation system. So the familiar weight, the smell, the warmth, the rhythm of holding the baby helps us to feel grounded. And this is also regulating for the baby as well. The baby's sensory needs and attachment needs are just as important. So when someone else holds the baby, it can feel like that safety is being removed, which leads to dysregulation in that dyad. And this can trigger shutdown, dissociation, or that irritability. And that could happen for the baby as well. I'm just going to skip to my last point, which is that I think it's really important that we validate the grief that comes with these moments, and the grief of not being understood by family, or grief that our parenting experience looks different from cultural or social expectations. So as clinicians, all different types of clinicians, holding space for that grief without judgment is a part of affirming that parent's strengths and their growing competence and their growing attunement with the baby. Yeah, I want to leave it there.
That's beautiful. Thank you, Sarah. We won't unpack that anymore, but that was a very nice response and gives us lots of food for thought. And again, no one response is going to answer that question, but you've given us a number of pivotal ways to think about that experience for an autistic person. Thank you so much. All right, I've got one eye on the time, but we do have one final question, and I'm going to continue with that question before we finish up. So we will do a soft finish beyond the hour. Stay with us if you can, but if you need to go, know that this is being recorded. And this is another big question, actually, for you, Amy. So you're back in the hot seat. There is a bit of preamble to this question, which the person who provided the question provided a bit of of detail. I'm going to go ahead and read that detail so that we have the context for that little cluster of questions right at the end there. So this person has said, a question to Amy's presentation on the infant's experience. Your quote that ADHD parenting may look unconventional really resonated with me personally and professionally. And also your quote that the intention for connection is what's important. I've been thinking about how to make care mutually affirming of both baby and parent. The baby as manual concept is so helpful to this. And we as parents are our own manual, but as late identified ADHD parents, we are still relearning how to read ourselves, often after a lifetime of being told by the world and lots of people in it to mistrust our bodies and our experiences. I'm wondering, how might we help ADHD parents attune to their infants while also learning to attune to themselves, especially when at those tricky moments there might be, say, not so good goodness of fit between the infant's needs and the parent's needs. And the person has given the example, let's say there's an unsettled infant with a high need for close physical contact and being on, for regulation, for felt safety, but a parent who is quickly overstimulated by that touch. So when there's not a goodness of fit there. So how do we help the parent give language to this in a helpful way rather than a stuck way? How can we be mutually affirming of both parent and infant? There's a lot in that. Actually.
Yeah.
Yeah.
And I can't shorten my answer.
We're not asking you to shorten anything. You just respond as you will, and it will take the time that it does because we make accommodations here.
I also just wanted to say that although I'm answering this according to that question, I think the ideas are relevant to the couple relationship. And I also want to say that what I'm going to say ties in really lovely with what Sarah's just talked about as well. So if the way that I explain it doesn't quite fit for how your brain works, if Sarah's stuff did make sense, like try and draw that in to what I'm saying. So, because I think the question really gets to the heart of what mutually affirming care is,
Yes.
right? So, many late identified ADHD parents are learning to read their babies. And, like, let's face it, I've got an almost 12-year-old and a turning 10-year-old, and I'm still learning this stuff, right? Um, so, we're learning to read our babies, our toddlers, our children's cues, while also relearning how to read ourselves. And this is after years of being told to, or taught, and not necessarily intentionally, but to not trust our bodies and our instincts and our sensory experiences.
Mhm.
And so that means that attunement is not just a parenting skill, but a profound act of self recovery, right? And sometimes the baby's needs and the parent's needs don't match. Like when the baby does crave constant closeness and the parent is feeling overstimulated by touch. And these moments can trigger deep shame. Like, why can't I handle this? Or am I failing my baby? Or even like, don't I love my baby enough? Right? But what if we reframe those moments? So instead of seeing them as problems to fix, we can view them as opportunities to gather data. And we autistic folk love that, right? So these neuroclashes can offer insight into both the infant sensory world and the parent's nervous system. So we can support parents to step into a role of being a curious observer with reflective questions like, what was happening in your body just before things felt too much? What might your baby have been needing or communicating? Was there something, a change in pace, a position, or an environment that helped either of you to regulate? Right? And notice that these kinds of questions are not us telling them, but helping them to kind of go back and consider the context. And when the parent feels overloaded or self-critical, we can offer compassionate inner language like, this is really hard, and I'm still showing up. I'm learning what works for both of us. I'm not broken. I'm building connection in a way that honors both of our needs. And alongside this, we can gently draw attention to what's already working. But even in the midst of the most overwhelmed dyads, there are still micro moments of attunement. And it might be one shared breath, a sigh, right? A softening in the body, a moment of stillness. It could be a brief moment of eye contact, right? Not like gazing. We can help the parent reflect. What supported that connection? What might that tell you about your baby's preferences and your own intuitive parenting strengths? To help parents experience this in real time, I often suggest a watch, wait, and wonder activity and adapt it for neurodivergent needs. And so when I describe this, I want you to know that I never follow any script. Like, I know you'll see me using a script to present. I actually don't script anything. I don't script any reflective mindfulness, anything. I have now my own intuitive sense of how to adapt all of that stuff that I know with any particular client. So although this will read like a script, it's not being used in that way. So here's how it would work. So I might invite the parent to spend, depending on their capacity, 5 or 10 minutes, but it could be 1 minute, okay? Observing their baby when they're calm and alert, not trying to play or direct, just watching, just sitting and watching their baby. But crucially, we help the parent meet their own sensory and pacing needs while doing this. So this might mean sitting in a dim, quiet space with low sensory input. It might mean using noise reduction headphones if they're in a busy home. It might be that they've got a grounding object, like a weighted pillow or fidget. And I've got my Squishmallow here today. It might be having like a cup of tea that they're sipping. It might be gentle rocking. It might be using a foot massager, right, to stay present. And very importantly, it might be setting a visual timer so that they know that this is time limited and predictable, because I can't tell you how long I've spoken for already, right? So a parent that is feeling overwhelmed at the thought of watching their baby, it doesn't matter if you tell them it's 1 minute, they can't predict how long that is. They need to have it timed, and that is completely okay, because then they can relax doing it, okay? During the observation, they might notice how their baby moves, and I'm going to talk to them about what they might notice, breathes, or makes sounds. And afterwards, we can invite gentle reflection. What did you notice about your baby's communication or sensory style? What did you notice in your own body? What helped you to regulate? Was there a moment of connection? If there was, what helped create that? If there wasn't, what got in the way, right? This process helps the parent begin to build what I would call dyadic sensory map, a personalized understanding of what supports both parent and baby to feel safe, seen, and in sync. And most importantly, it reinforces that we don't need to erase or override difference to build connection. We need to understand it and respond with creativity, curiosity, and compassion. Because attunement is not about perfection, it's about noticing and wondering and repairing. It's about holding space for the baby's need for closeness and the parent's need for regulation without either being pathologized. And that's what makes truly mutually affirming care.
Beautiful. Thank you, Amy. There's a lot there. It was a big question, so there's a lot of food for thought there in your response. I appreciate that. I'm sure everyone else does too. In the service of time, I am moving us along now to the end of our time together and a few closing points. We do hope you have found this super extra bonus hour with us helpful, valuable. But we want to let you know a couple of things. First, there is a wonderful resource that has just launched this week. We are pleased to share with you this very special resource for autistic folk in the perinatal period. It's the Aspect Autistic Pregnancy and Parenthood Hub. It's an innovative digital resource developed by Aspect, the organisation, and particularly the Research Centre for Autism Practice within Aspect. A big shout out to Abby Love, who was the lead in the development of this resource. Again, it's called the Aspect Autistic Pregnancy and Parenthood Hub. It's Australian and it's wonderful. We are dropping the link to that website in the chat now. We will also share it in our follow-up email and we will share it on the socials as well. Please do spend some time having a look at it, share it with your colleagues, share it with your clients and patients. Next to drop in our chat is our link to our post-conference survey. Please fill out the survey. We know that the return rate for completing surveys after an event is low. Let's do things differently here. Let's change that, shall we? It shouldn't take long. It's anonymous. Because I have a healthy obsession with data and feedback, I can assure you, if you take the time to complete the survey, I will be taking the time to reviewing all of your responses and reading all of your comments. So I thank you in advance for that. Your responses will help inform future events, what you want to know more of, and what you found helpful. That's very important for us as a presenting team, but also for this field of inquiry. A note on certificates. Yes, we will issue certificates. They'll be issued in about a week and a half. Why? Because we're holding out on you. We would really love everyone to complete the survey before you receive your certificate. So yes, the certificates will be forthcoming, but we will be sending a reminder about the survey. Please fill out the survey and then you've completed the conference and you can get your certificate. All right. I will sign off now with a note of gratitude. Thank you to everyone who has supported this conference. To all of you as ticket holders, thank you. To our wonderful presenters, including their responses today, thank you. To our supporting organisations, thank you. And to Abercrombie Management for organising this event, thank you, Nikki. So that's a big note of gratitude to everyone. Thank you all. Goodbye for now. Thank you.